I'm Angelina. And what I do for our patients here at Davis Hospital is when a patient has a cancer diagnosis, I work with that patient to be able to, for those of you in the back, sorry. I work with that patient and help them get to the necessary medical professionals that will become a part of their care team. I also schedule imaging, I coordinate your care, provide a lot of patient education, and help get to community resources that can be beneficial to you as you're going through that trajectory of that cancer care. So I do a lot of, just a lot of hands-on support and provide a lot of information.
Okay. So I have several roles that I play in the management of cancer. Oftentimes I'm called upon to help make the diagnosis by obtaining some tissue that we can send out to the lab and get a biopsy. So whether it's a lymph node or a lesion growing on the skin, or if we're doing a colonoscopy, a biopsy of that to make the diagnosis. And then once the diagnosis is made, Angelina will refer a patient to my office for whatever surgical treatment is required for that tumor, whether it be a lumpectomy or a mastectomy or a colon resection or resection of some skin or lymph nodes. And then once the tumor has been removed, or sometimes even before, I'll get involved with providing vascular access for the oncologist to use to administer chemotherapy. We'll put a device in that's called a port that the patients can use to get their chemotherapy without having to get an IV stick every time they come in. So that's what I do.
So about 2/3 of the patients who are diagnosed with cancer will need radiation therapy as a part of their care. And that's what I do. I deliver radiation therapy. We work in conjunction with the surgeons and the medical oncologists to fit these different therapies together in ways that have been proven to be the most efficacious while minimizing most side effects. And so when I was working back at the NCI, we had the ability to do a lot of high-tech treatments that went a long ways to lowering side effects from cancer care. And I was frustrated that more people didn't have access to that. And so when I joined Gamma West and came out to Utah, our goal was to bring some of these high-tech advanced treatments to the local community where you can get high-quality care close to home or where you're working so that your quality of life would be better. And so with that, we established several centers going from Idaho Falls to St. George that do just that. And I'm pleased that Davis Hospital was the first hospital that stepped up to partner with us to bring some of these high-tech treatments close to home. And so we've been endeavoring to do that so that you don't have to travel an hour and a half down to Huntsman every day for several weeks. And so it makes receiving cancer care a lot more easy on the family and those who are receiving the treatment.
Well, as a medical oncologist, I deal with, I think, really two main things. Number one, any medication that's given to treat the cancer, and then also long-term follow-up. So I'd say a good portion of the patients that come to see me never receive chemotherapy. They might receive some other kind of therapy, and some just need somebody to follow them that understands cancer. So a good portion of the patients I see each day are just there for monitoring of their cancer. I used to say to people, well, the best way to think of me is I'm a chemotherapy doctor. That's not true anymore. Certainly, we still use a lot of chemotherapy to treat cancer, but there are a lot of other newer drugs that are non-chemotherapy drugs that have been, that have been developed in the last 10 years or so. So more and more cancer therapies shifting towards what we call targeted therapy with antibody drugs or things that target the enzymes in cancer cells, and shifting more and more away from chemotherapy. There's really been a tremendous explosion of new cancer therapies in the last 5 to 10 years that has allowed us to treat a lot of cancers now that we had nothing for 5 or 10 years ago.
So isn't that wonderful that we have all of these cancer experts here as our part of our cancer team at Davis Hospital, where they really provide such an incredible service here. So let's learn some more. Who has questions? Can cancer spread to different parts of the body? How does the spreading of cancer cells attach to different parts of the body? And can the original cancers be located before spreading? So who would like to be first? Anyone who would like to address that question? It's a good one. Sounds like you.
All right. Yeah, that's the nature of cancer, is to spread, and that's the big problem. If you look at the cancers that are most likely to be cured, they're the ones that haven't spread yet. And the cancers that we have the best success with are the ones where there are good screening methods to find the cancer early, whether it's colon cancer while it's still in the colon, or breast cancer. We can screen with mammography, or prostate cancer with prostate exams, things like that. But there's something about the nature of the cancer cells that makes them spread, makes them migrate. And each cancer is not one disease, it's a whole bunch of different diseases. And every cancer behaves differently. And depending on the type of cancer you're dealing with, there are certain places that it tends to spread to. And why it does that, we don't really fully understand. But prostate cancer tends to spread to bone. Sometimes it gets to lymph nodes. It's very late for it to get into things like liver or lung, but bone is the main target for prostate cancer. For breast cancer, it spreads to lymph nodes, liver, lung, bone, and sometimes to the nervous system. So the pattern, where the cells go and why they attach to those particular organs or those particular structures, we don't fully understand yet. But we know enough about the pattern of spread so that we know where to look. Did I answer all of them?
Did you feel like that was?
Can you always find the original cancer?
No.
Why?
About 2% of cancers in this country that are diagnosed in this country, we call a cancer of unknown primary, which means we don't know where it started. It's spread somewhere, and we can't find where it started.
Where it originated?
Where it originated. So there are some newer tests, laboratory tests we can do on those tumor cells that give us a better idea about where it started, and then we use that information for the treatment of cancer. Because if a cancer is spread, it's still, say it's a breast cancer that's spread to the liver, it's still breast cancer even though it's in the liver. And the way it's going to behave and the drugs that it will respond to will be drugs that work for breast cancer. So when we can't find where it started from, we'll do these tests to try to better understand the nature of the cancer. Then we'll use that information to decide which drugs to offer to the patient. The theory is that a tumor will start, it will spread, and then the original tumor will sometimes involute, just disappear. We know the immune system is active at fighting the cancer, and sometimes it can eradicate the original tumor at the original site, but not until after things have spread to other places. That's the theory.
Well, the cells that spread, then do they spread again?
Well, that's always a concern. When the cancer is spread, then there's a high probability that we won't be able to fully eradicate the cancer. We may be able to treat it and control it. In some cases, we can buy some years for patients. But there are not a lot of cancers that we can cure once they've spread into other organs. There are some that we can, like lymphoma and testicular cancer in particular, but for most cancers we can't.
Anyone else want to respond to that?
So cancer cells, they spread through 3 different mechanisms, either through direct migration, or getting into the blood system and flowing with the blood, or getting into another plumbing system called the lymphatic system. Now there's cells in our body that are designed to spread, but most cancers don't have that ability from the beginning. It's the mutations they go through as a cancer cell that they develop those abilities. So that's why when we do screening, we're trying to catch these cancers before they've mutated and developed the ability to spread elsewhere in the body. So that's why screening is really important, because if you catch the cancer early on, then your odds of curing that cancer go up tremendously.
No surgical perspective, really? Just more work. More work for you. Okay, how's that? That was really interesting, wasn't it? Good. So, okay, another question. Are there any new screening tests to detect ovarian cancer early?
No, that's the answer.
No, there really isn't. And that's a real tough problem. Ovarian cancer, if we can find it when it's in the early stages, there's a high chance of cure. But the problem is we don't usually find it until it has advanced. So ovarian cancer, we stage it stage 1, 2, 3, 4. 3 being where it's spread throughout the abdomen, 4 where it's spread into other organs or outside of the abdomen. And stage 4 is incurable. Stage 3, most patients we can treat it, but they usually relapse. Stage 1 and 2, there's a high cure rate, but there are no symptoms, and there's nothing you can find laboratory-wise that will detect it, not reliably, in stage 1 and 2. So the only time we ever find it in stage 1 or 2 is when someone just happens to have their pelvic examination before the cancer is spread. And so we are not very good at screening ovarian cancer. That's why so many patients eventually succumb to this disease. We can treat it, but we can't cure it once it's a more advanced stage.
Yes.
Thank you. And let's ask, how can a navigator help me once I am diagnosed? So that's going to go to you. And I think I would love, after you're done, if Dr. Wilson could give us his kind of perspective on how the patient navigator helps his patients.
I work a lot with breast patients in particular. We work on a lot of other patients here in the area, but the majority of the patients that I see, I come to me through mammography, so I'll use that as an example. For my ladies that come in to mammography and it's deemed necessary to have a biopsy, I'll work with that patient from that point on. After she has a biopsy, we start to develop a relationship. I may not know the outcome of that pathology, but I call her, ask how she's doing, make sure she's doing well the day after the biopsy, and then we start talking about when those pathology results will be available. She'll come into the office and she'll meet with me and we'll talk about those pathology results. At that time, I'll help get a team together as specialists, which will be just like the gentleman to my left. And so you'll need a medical oncologist like Dr. Johnson, you'll need a radiation oncologist like Dr. Harris, and you're gonna need a surgeon like Dr. Wilson. That makes up a team of specialists that a patient would need. In addition, I provide them a means to stay organized. It's just a binder, but it's a beautiful binder which you put all of your imaging and your pathology in. Also in that binder are some other resources that are available. Many patients are scared. They don't know what's going to happen next, and they don't know what to ask those doctors when they get into the office. Sometimes we just shut down because we're so scared of our diagnosis. When I sit down with a patient in that binder, they really have an idea of what to ask those doctors. So when they go in, every little section is divided into helping those patients formulate the questions that they're gonna feel better knowing the answers to, and their family members. So as a navigator, I help set those patients up with physicians, and then it's a continuous process of helping them get to the necessary tests, such as imaging, additional imaging, maybe an MRI, maybe a PET scan, maybe other imaging that the doctors need. I take that patient at that point and we present them at a multidisciplinary tumor board. It's a meeting that we have twice a month with these 3 physicians and many others, and it gives an opportunity for those doctors to collaborate. And we discuss all of the cases. They are able to review it with the pathologist and ask him particular questions about the tissue and how that tissue responds or is responding in the body and how the body is reacting. It helps them know what that patient will need, whether it is targeted therapies or chemotherapy or maybe just surgery and radiation. So in that meeting, all the doctors are able to communicate. Sometimes those cases are pretty clear cut, and they're able to say, oh, okay, we know exactly what we need to do. Other times, it gives them an opportunity to discuss different therapies with the other physicians that are also in their specialty, or to be able to coordinate the care. Well, we're gonna do surgery first, and then maybe we'll do chemotherapy or targeted therapy, or maybe we'll do radiation, and that whole scenario can be different with each and every patient on which therapy needs to happen first. And it gives them all an opportunity to work together. I can say on behalf of all of our physicians right here in this area, they work so well together, and they keep great communication with me. If a patient is in need of something, they'll reach out to me and say, can you help get this? Can you help the patient with this, or whatever? We also offer genetic testing here at Davis, and I'm able to use a variety of laboratories that can meet patients' needs for the type of cancer that they have. It's a real easy blood test, and for some cancers, it provides vital information for them. So those are some of the things that I do as a navigator. Did I answer that?
I think so. Very good, thank you.
Okay. From my standpoint, the thing that I've noticed, well, a couple of things, but we started the navigation program here about, 6-7 years ago, I think. And what used to happen is the patient would, say, for example, breast cancer, that's the most common one we see. They come in, they get their mammogram, they may have a biopsy, and then once the diagnosis of cancer was made, it was just kind of like, well, there you go, good luck. And patients, as she said, they didn't know what to do. They didn't know what was involved, and they would reach out, and they'd go try to find somewhere to go, and they'd end up a lot of times going down to Huntsman or something like that, things that we could easily handle here, and so patients were having to travel a lot of extra distance. And it also gives them someone to ask the simple questions of, when they meet with her, they get a pretty good idea what needs to be done, whereas before they had the cancer diagnosis and they didn't know anything, where they needed to go, who they needed to see, and they had to call and set their own appointments, and there was just a lot more work for them. It's just really facilitated the process for the patient, made it easier, and they come in now and they have their little booklet with questions that they've looked over, and so they know what questions to ask, and sometimes Angelina has even accompanied patients on their visits to the office with me. Most patients will have a family member or somebody come with them, but there are patients who don't have family members here, or for whatever reason she'll come along and be an extra set of ears, so that she can hear things that they missed or maybe didn't pick up on. And it's just really, it's eased their anxiety, it's kept them here local in the community, and they just have a better overall experience. It's really been a great addition to the program.
I really like working with Angelina because it just makes it so much better for the patients, because sometimes there's questions that you may be intimidated calling the doctor about, or don't know which of the doctors you need to ask that question of. You can ask Angelina, and she can either answer the question for you or find the right person to answer that question for you. It's nice having like a friend in the business, and that's the way I view Angelina's role. She's a friend in the business who can make your journey so much more easy to navigate.
I think, I've been in practice for 24 years, and the old way was somebody would go to their primary care doctor, and they'd find a lump or have a complaint, or they'd end up with a test, a biopsy, then they'd have a diagnosis, and then the primary care doctor is trying to figure out who to send him to. And they usually call, the medical oncologist, and then I'd call the surgeon, and then, it was just piecemeal, and everyone's kind of scrambling to get people pulled together, and having the navigator does two things. Number one, it really expedites things. Things happen very quickly, and having been a patient myself, I can tell you, if you've ever been a patient, and I suppose a lot of you here have, when you've got a diagnosis, you want answers quickly, and you don't want to wait a week or two to get in to see this one and then that one and whatever. But to have someone that coordinates everything and gets the patient in quickly to get answers from multiple sources and coordinate the care is really important. And that's what the Navigator system is doing here at Davis. And the tumor board that she met, this meeting that we as doctors have together on a regular basis to discuss case by case the situation, I think is very helpful, because you get a whole bunch of minds thinking about the same patient all at once, and everybody giving their comments, and so we come up with solutions that make sense from multiple different people and multiple different specialties all at once. So I think it's really improved the care here in these areas.
Absolutely. Great, thank you. Great question and great responses. I skipped one earlier, I apologize. Is there anything to help neuropathy of the hands and feet after chemotherapy? No.
Time.
Time.
Just time.
Time,
Yeah,
okay.
well, let me
You can elaborate?
All right, someone here must have had chemotherapy and had neuropathy. Neuropathy means numbness or tingling in your hands or feet. A lot of the chemotherapy drugs that we have will cause that, and it's a long-term problem. It can take a long time to go away. And whoever figures that out and comes up with a cure for neuropathy deserves a Nobel Prize. It's just a real nasty problem. And so the best thing that we could do is to prevent it. There are things that your medical oncologist can do during the treatment that minimizes or slows the development of neuropathy. Because however much neuropathy you've got by the end of the treatment is going to determine how long it takes for it to go away. If it's up to your wrist, it's going to take longer to go away than if it's only up just to your fingertips. And it tends to spread, from the fingertips up the hand into the arm, from the toes up to the legs. So there are things we do to prevent it or to try to minimize it, but once it's there, and it's just time that makes the difference.
Perfect, thank you. This question, why is your radiation treatment different, or how is your radiation treatment different than at Huntsman? So I'm going to give that to you, Dr. Harris. And we're going to have a change of the guard here and let Diane facilitate for a moment.
So the way we've been delivering radiation for the last several decades hasn't, the machines haven't changed so much as far as the amount of energy they deliver and the ability to point a beam at a tumor. What has changed is our ability to shape where that radiation is deposited within the body. There's been a lot of changes in the computer power that we have to plan people's treatments, and also the images that we achieve that can show us where the cancer is. And so about a decade ago, we started to develop some new techniques called intensity modulated radiotherapy, where instead of aiming straight on and hitting the tumor from maybe 1, 2, or 3 angles, we could divide the beam and shape it and aim at the tumor from multiple angles. And the way we shaped it, that would put a nice high dose around the target tumor, but it would keep the rest of the tissues in the fairly low or no dose region. And so when we did that, we could actually raise the dose that we were delivering to the cancer and lower the dose that was going to the nearby critical structures, the sensitive structures, the ones that cause the side effects from the radiation. Once we had that ability, we had to be able to deliver that targeted treatment to the same spot every day. And so we needed some form of imaging to place that target each day at the right position. In the beginning, we used ultrasound, but now we use a machine that has a CAT scanner integrated into the delivery system. So right before treatment, we line you up using external landmarks and immobilization devices. But each tumor can move a little bit inside your body because we're living, breathing creatures. And so right before treatment, the machine will do a scan of the tumor and lock on target internally to make sure that that high dose is delivered right where it needs to go. And so many of the machines that we have out in the country have been retrofitted to try and do these new techniques. But there's only one machine that was designed from the ground up to use these new techniques and take advantage of them. And that's a tomotherapy unit. And right now there are 4 tomotherapy units in the state, but still none down at Huntsman. So we're very pleased that we can offer this state-of-the-art treatment to the local community, especially for people who don't have the ability to travel for it.
And Davis was the first to have tomotherapy.
How many years have we had?
6 years.
What is the normal time period for radiation treatment?
So the time period is based on the type of tumor we're treating and the goals of treatment. So we integrate a lot of our treatments. So sometimes it makes sense to do surgery with radiation, then you won't need to do all of your treatment with surgery or all your treatment with radiation. So the time is variable depending on how many different treatments you're getting, different modalities of treatment you're getting, and also what particular cancer is being treated. Sometimes the objective of treatment is to cure the cancer, but sometimes cure is not possible, and then the objective of treatment is to make your quality of life better. For example, if the tumor is causing you pain, then we want to take that pain away. If it's making it hard to breathe, how can we improve your breathing? And so those things all feed into how long your course of treatment will be. Basically, the biology of treatment is that most of our treatments are delivered on a daily basis, Monday through Friday, over a period of weeks. And for those palliative treatments, the ones that aren't going for cure but are trying to make your life better, those typically take about 2 weeks. For curative treatments, those can take typically around 6 to 8 weeks. And so traveling for treatment becomes quite problematic when you have to, do that daily basis for several weeks. There are also other types of treatment that'll deliver a very high dose of radiation in one treatment. And these are what we call radiosurgery, where we can completely eliminate everything within the target tissue. But typically we don't want to eliminate everything because the biology is such that we want to spare the normal tissues and just kill the cancer. So most of our treatments are fractionated so that the normal tissue recovers each day between treatments while it still kills the cancer cells, which are more susceptible to the radiation. So the answer is anywhere from 1 to 8 weeks, depending on what your situation is. Each treatment usually takes about 15 to 20 minutes a day. The treatments are painless. You hear the machine running, but you don't feel anything at all. Typically, if you're going to have side effects from the treatment, those will arise 2 or 3 weeks into treatment. They come on very gradually increase over the course of treatment, and then after treatment gradually go away over a period of days or weeks.
You're getting good at this. What are the most common types of cancer that you treat, and are there any cancers that you find more here than you would expect?
The most common cancer that I see and treat is breast cancer by far and away. The cancer that I see less of here is lung cancer. There's a lot less lung cancer in Utah than in other places in the country. I practiced in Arizona for 8 years. I used to see a ton of lung cancer. Don't see much of that here. But breast cancer is at the top of the list. There's a lot of prostate cancer, but it doesn't make it to the medical oncologist that often. Usually the urologist takes care of it and then the radiation doctor. Let's see, colon cancer is kind of high on the list. Those would be the most common. Lymphoma probably in there too.
Right, so what you see as far as cancer prevalence nationwide, you often see in Utah, except for the smoking associated cancers. We see less of those in Utah, and those include the lung cancer, the head and neck cancer, a variety of other cancers, but bladder cancer. We do see all those cancers, but we see less of them in Utah than we saw when we practiced in other locations. But by far, for women, breast cancer; for men, prostate cancer. Lung cancer is still a very important problem because both men and women get it, so there are large numbers, but again, less than we would see elsewhere where there's a lot more smoking.
Yeah, I also see the vast majority of my cancer patients are breast cancers. Unfortunately, about 1 in every 9, 10 women in this country will have a diagnosis of breast cancer at some point in their life. So we see that a lot. I also tend to see a lot of skin cancers. We do little biopsies or excisions, especially in this state. We have a lot of fair-skinned people and we get a lot of sun. So that's a prevalent one. And then we'll see a smattering of colonoscopy or colon cancers and esophageal cancers from our endoscopy.
You're done. Whole question.
Yeah. Are there more questions out there?
We do see rare cancers as well. You know, there's stuff that pops up out of the blue in rare occasions elsewhere in the country. We see those things here as well.
This is my question. When you see skin cancer, what are the most common ways to cure or take care or treat skin cancer? I'm from Arizona, so it's a concern.
Yeah, the vast majority of skin cancers are successfully treated with a surgical excision of the lesion itself and some surrounding skin. Fortunately, most of what we see are fairly slow-growing tumors like basal cell carcinomas or squamous cell carcinomas that if you just get a little margin around them of normal tissue, that's usually curative. We will see melanoma, which does require sampling of the lymph nodes. It has a higher potential to spread. And then there are some other options available to treat those as well.
In radiation, we treat a lot of skin cancer as well. In most cases, if it's a small spot on your arm, it's easiest just to have that spot cut out. But if that spot's on the tip of your nose or your eyelid or your earlobe or some place that would cosmetically cause a significant deficit, then in those cases we prefer to treat with radiation because we can kill the cancer, preserve the organ, and you still look great.
Medical oncology, we rarely see most skin cancers. The squamous cell carcinomas and basal cell carcinomas that Dr. Wilson mentioned are by far and away the most common cancers, any kind of cancer. And a lot of them don't even get to the surgeon, they just get to a dermatologist where they're frozen off or scraped off. So they don't make their way to my office because there's no involvement in the body. Else, it doesn't spread beyond the skin. Melanoma is the nasty one. Melanoma, as Dr. Harris mentioned, tends to spread early. So that's the nasty type of skin cancer. And that one is a tough one to treat. Once it spreads, we didn't have anything up until about 5 years ago. Now we've got about 6 or 7 drugs that work for melanoma. But we don't have a cure once it spreads.
How common is pancreatic cancer, and are there any early symptoms to look for?
Pancreatic cancer, it's not a real common cancer, but there are probably about 30,000 cases per year in this country, if I'm remembering the numbers right. So it's not rare. I see a fair amount of it. It's usually treated mainly with chemotherapy plus or minus radiation. If we can catch it early, it can be treated surgically, but it's really hard to catch it early. And just speaking globally, the cancers that we do the best at, like I said earlier, are the ones that we have good screening techniques to find it before it's spread. Pancreatic cancer is often, it doesn't cause any symptoms, it doesn't cause any physical findings until it is more advanced. And so there's not a good way to screen for it. And sometimes someone's just fortunate enough to be in the doctor and have this problem or that problem that gets looked at and find the cancer before it's had a chance to spread to lymph nodes or the liver. Once it spreads, then there's not a cure for it. Survival from a pancreatic cancer was less than 6 months. With chemotherapy and different things that we can do, most patients can usually get a year or sometimes 2 years. So we've made some headway there, but once it's spread, there's not a cure. There's just not a good screening technique for pancreatic cancer.
So going forward, what are you most excited about when it comes to treating or curing cancer? Is there anything on the horizon that you can share with us that gives us some hope?
People ask me all the time, when are you going to cure cancer? I try to tell them, I cure it every day. The thing is, you have to look at individual diseases. It's not one disease. And if you look at breast cancer, which we've talked about a lot today, there are about 210,000, 215,000 cases per year in this country. If you look at the number of cancer deaths, it's about 40,000. So you can do the math. Most patients with breast cancer are cured of their disease. And most of the cures come from surgery. We enhance the cure rate with radiation and chemotherapy and hormone blocking medicines. But we cure a lot of patients. And colon cancer, we cure a lot of those. Prostate cancer, we cure a lot of those. I think the most exciting part about cancer care is that two things. Number one, we're a lot better at treating the problems that come with cancer and the side effects of the chemotherapy. We're very good at controlling nausea these days. We're very good at keeping blood counts up to a safe level so people on chemo don't get bad infections that carry them to the hospital. We're better about improving their appetite so people can eat and function more normally when they're getting their treatments. So these, what we call ancillary treatments, things to make you feel better and to be able to tolerate the treatments better, have really come a long way. But the other thing that is, I think, real promising are what we call targeted therapies. And by that I mean these are drugs that are targeting the cancer cells themselves, as opposed to chemotherapy, which the basic premise of chemotherapy is that it kills cells that are rapidly dividing. Well, cancer cells divide more rapidly than other cells in the body, so more cancer cells get killed than everything else. But the kill isn't limited just to cancer cells. It has an impact on everything else. With the targeted treatments, they're going in and targeting the cancer cells specifically, some feature of the cancer cell that these new drugs will go after. And so there are a lot fewer side effects to the rest of the body. And so that's an interesting development, and it's come a long way, very rapidly, just in the last 5 or 10 years. So we've made a lot of headway with cancers that we couldn't treat before, or cancers that are advanced that we've run out of chemotherapy to use for. So those are, you know, at least in my world, those are the things that are most exciting to see happen with cancer care.
By raise of hands, how many people think 1989 was a long time ago? I don't think it feels that long ago. I was a second-year medical student, and we were in immunology class, and we were learning about the immune system. And the instructor said, you know, this is what happens inside a mouse. We don't know what happens in the human, but this is how it works in the mouse, because we've been able to study the mouse system. And I was amazed at how much we didn't know in 1989. We have learned so much since then. Our ability to understand what's happening inside the cell at the cellular level has changed tremendously. And a lot of these focused or targeted medicines that Dr. Johnson was talking about have come out of our understanding of what's going on inside the cell. And if we can focus on those things that happen inside a cancer cell that are different than the normal cell, then we can get a tool to focus and kill that cell uniquely. And so that's the big thing that excites me about cancer care going forward. Unfortunately, cancer is not one disease. It's a family of diseases. And so if we find one key to one particular type of cancer, it won't work with all cancers. And so there's so much work that's ahead of us to do, but it is pretty exciting the amount of knowledge we know now versus a few short years ago.
From a surgical standpoint, most of the advances have been in minimally invasive surgery, for example, laparoscopy to remove a colon cancer through several small incisions versus a big incision that would take 6 to 8 weeks to heal. We can now get patients back functioning again in a couple of weeks. For example, breast cancer, the treatment for that used to be a mastectomy and remove all your lymph nodes, and a lot of women would end up with a swollen arm from the lymphedema. And now we're learning more and more that we can get by with just a sampling of the lymph nodes and then just removing a portion of the breast so that there's not as much disfigurement, as much surgery. The Da Vinci surgical robot has come out and allowed certain centers to perform things like pancreatic tumor resections through very minimally invasive procedures and just really improving the quality of life for people after their surgeries, so it's not so debilitating. And then the research keeps coming out about, do we need to go take out lymph nodes, or can we leave them in and avoid all the potential complications from that? And every year things are changing, and as Dr. Harris said, we've just in the 20 years or so I've been doing this, it's drastically changed how we approach things. We used to do a biopsy by making a big incision and taking out the whole tumor. Now we just do a little image-guided needle biopsy that's real easy, and it just a lot of advances in that way, making life better for people. So.
I think that I'm most excited about the public awareness to screening opportunities for patients. We can have a yearly skin check, a mammogram for women, prostate check for gentlemen. We've talked about the most common types of cancers that we have here in Utah, and those are, but unfortunately, our ladies are not being checked regularly. And this is an opportunity for you to share what you learned here today, which was and is, Utah has one of the lowest rates of mammography screening. It's pretty shameful when I say one of the lowest. I think there's only one state currently behind us, and that would be Idaho. We are not having our regular yearly screens. And if we can detect a cancer that is smaller than an eraser by mammography, then we know that the treatment for that would be less than if that had the opportunity to grow and grow to the top of this cap, and then I see them even larger to 3 centimeters. So if we can catch it early, so screening is the key. And if we just start with those simple things, educate our families, our daughters, our granddaughters, mentioning it to your neighbors. It's time to get the awareness out, and it is out, and it is improving, but we still have a long way to go here in Utah. We still have a lot of education and a lot of opportunities to stay healthy.
Okay, as the chemotherapist, I can tell you, if a woman has a mammogram and a tiny tumor is found, she most likely is not going to need chemotherapy. If she waits a year and a half until the mass is large enough to feel it, she probably is going to need chemotherapy. That's the difference that screening, early screening makes. My cancer training was in North Carolina, and people didn't do a lot of screening back in those days either, and patients would come in with these big tumors that were, easily you could feel on examination, and it was really, that was kind of what I grew up on, what I was used to seeing, and those patients all needed chemotherapy. I finished there, went into practice in Sun City, Arizona, which is a nice retirement community, and down there, there are bridge clubs and, golf buddies, and everybody gets together. They have nothing else to talk about, I guess, and they just sit around and talk about their latest mammogram. It was about a year before I saw a tumor above 1 centimeter. That's less than a half an inch, because everyone down there was getting their screening mammograms, and their cancers were being found while they were small, and they were getting cured, and they didn't need chemotherapy. That's the difference that it makes. The same thing with colon cancer. If you get a colon cancer diagnosed early, or better yet, you get a colon polyp found and removed before it has time to turn into a cancer, you'll never see me, and you're not going to need chemotherapy for anything like that.
Well, we're out of time. Any final comments from any of our panels?
He's a really nice guy, so if you do have to see him, it'll be a pleasant experience, but it's better not to have chemotherapy.
Well, thank you so much for your time today. My goal is to put all of you out of business, and maybe you can practice medicine for something different than cancer, but we so much appreciate you taking time out of your very busy schedules. If you have any questions for them, you're more than welcome to leave them with us. We can pass them on to Angelina, who will get with the physicians, and we also have their contact information on some sheets that we gave you. So with that, again, thank you very much to our panel of experts and to our seniors. Have a wonderful day.